Welcome to the Medic Materials Podcast. If you're here for buttoned-up EMS professionalism and HR-approved opinions, you're in the wrong damn place. We talk real EMS, talk about some fucked-up calls, bad decisions, some system bullshit, and the stuff you only admit in the truck at 3 a.m. We will absolutely try to sell you some merch. Thank you very much. Accidentally teach you something. Maybe occasionally say something smart in between the sarcasm.
That makes more sense.
So kick the kids out. I'm like, let's turn it up.
I went to the Rangers game this week, so I had to match my nose ring.
Yeah.
Yeah.
Hey, look at me with my king size up skills,
Guys, not notice that nose ring.
Nah, worked with her for 2 years, 3 years.
You're not the first person that told me that this week. Don't worry.
Oh, really?
Yeah. Maybe I'll change it to red and see if it does noticeable.
Hello and welcome everyone back to the Medic Materials Podcast. How are you guys? That excited to be here?
That sounds thrilled.
I know, right? Like, man, should send him some.
Noise.
I should send him some chocolates or something, man. You got to get your pep in your step.
Yeah. Working on it.
We're working on it. That's right. We're working on it. So welcome back, guys. Welcome back, all of you guys who are listening. So I have a fairly, like I was saying to you guys, a fairly straightforward call that lends a lot of interesting talking points and education points that we're going to hit today. Some good discussions to be had. We also have our first to be able to make fun of. Sorry, fireman, but I am going to let the cat out of the bag. We have our first inner city 3 paramedic fireman crew today. So
That's
I
got to
think
be one hell of a budget.
Right? I mean, I wrote in large city, and it was a large metropolitan area that this call came from. So
I have budget envy.
Give me the money. Where's Mr. Krabs? Hold on. There we go. Okay, Mr. Krabs. There we go.
Mr. Krabs.
Yeah, Mr. Krabs with the ka-ching.
Okay.
But let's see if I can get in some of my intros here. Miss Emily.
Certified badass.
How are you? Enjoying the air?
I'm loving it.
I know. We're gonna ask you that until you come and tell us that you absolutely hate it.
I don't think I'll ever say it.
Yeah, that is true. I'm actually really interested to hear your take on the hospital aspect of the call today, as well as the finer points of some breathing control and like breathing management that we're going to talk about later on. So I think that the critical care experience from the MAHA and then the air medical experience and the in-hospital, I think will be some valuable information for listeners. But to let's see.
Speaking of which, the MAHA one-upped a physician this past week.
What?
Yep.
I will drink to them.
How in the Sam hell did that happen?
Straight.
So I get a text from the missus from work, and she axes what the hell was it again?
RTW,
right? She's like, what does it mean when it says RTW and left ventricular hypertrophy? And I was like, I'm like, why? She's like, well, because the doctor here doesn't know either. And I was like, I could ask the MAHA.
Because
so
that's what I do when I don't know something.
so I asked it him, and he comes back and says, "Oh yeah, I did. It was this, that, and the other thing." And I was like, I sent it in.
So
And,
advanced, you don't even remember it now. That's what I love about this story.
Yeah, I like to keep things, where I can pivot either way. So, you know what I mean? I like to pivot, and so then she tells the doctor, and the doctor says, "Oh no, it isn't." And apparently another doctor who was like into cardiology or something overheard the conversation and like leaned out of their office and went, "Yes, it is," and then proceeded to explain why.
That's
It was
The new way it's a new way to measure the actual hypertrophy size of your ventricle when.
no shit.
Yeah.
Well, I mean, just for that, I think
size matters.
Size matters. We got to give the Maha a yeah for that one. That don't happen very often. But yeah, I think
Big Dick the Doc.
Absolutely. Honestly, with all of these different companies and stuff like making their own AI platforms, I say we invest in Maha AI and just duplicate the Maha's brain in AI and then make it a search engine. What is this?
I say let's just find a sleazy lawyer who will file a lawsuit against the current administration for copyright infringement because we had the Maha long before there was Maha.
I mean, yeah. But if you're really going on radio personalities, the Maha was well before our time too.
Like I said, sleazy lawyer. They can make it happen.
I wouldn't want to do that to that Maha. The lovable little fuzzball from South Florida.
Well, maybe they'll, might be one of those things where they just, throw enough money at you to make you go away.
Maybe. And then we could afford the AI. It'd be perfect.
And then we can make the AI Maha.
Damn.
There you go.
So cool.
A circle of litigation.
There you go. So let's get through this rig check here. So just remember, I want you to stop sitting and just clicking through CMEs online, pointless jibber jabber with no actual learning. You can listen to this show, earn CME credit, and do your entire research listening to our madness. I think that is like the coolest thing in the world. So if you're looking like a individual provider or an agency, thank you. I'm throwing this shout out in for free. Thank you, Silver Waters, for signing up with Medic Materials recently here. If you're an agency looking to offer your staff a better way of learning, go to medicmaterialscmeacademy.thinkific.com to find out more. In my free time, because I have a gaggle of it now, thank you for the fancy word, Gerard, I'm actually redoing the entire CME website. So We're going to do a lot of really cool things to help you guys find the CMEs that you're looking for that much easier. Big conference alert. Come and meet me at 2 conferences upcoming. The first one, the Finger Lakes Regional EMS Conference in Geneva, New York, February 26th through the 28th. I'll be speaking 4 times there. And the Primary Assessment Conference in Lake Placid, New York on May 13th through 17th. I'll be speaking 1 time there. Vendor at both. These are by far 2 of the coolest, best, most affordable small EMS conferences in New York State. They get a really good turnout. They get really good, high-quality speakers. Look at me. I'm going. So, duh. And lastly, shout out our listeners in the island of Great Britain and the great state of Ohio.
The island nation.
The island nation.
Yes. The former empire.
That's right.
Yes.
Yep. So.
You got something on fire behind you.
I do. No one can see it. It's a candle.
I can see it.
You guys can. No one on the actual podcast can see it, but it's a candle.
Okay, there it is.
It is Cashmere Antique.
Cashmere.
It's a highly fragranced premium wax blend. It says cashmere, leather, rose, red cedar, teak, and moss-scented notes.
Ooh.
It does actually smell really fucking good in here, though.
It sounds like the kind of candle like someone who like pays someone to wipe their ass would have. You know what I mean?
I mean, you get what you can afford, and sometimes it's worth paying the extra dime.
Yes, wipe with more feeling, damn it.
Just get a bidet, be fine. Then you don't even have to wipe. You just take a shower on your starfish. So sorry.
Chocolate starfish.
Oh, and that hot dog flavored water. So, guys, are you ready?
Yeah.
Or
am I right? No, I'm Gerard, but I'm ready.
All right, you're ready. Here we go. So, your system, as I alluded to before, is a large inner city metropolitan fire department.
Fat budget,
right? They got money flowing out of every orifice. We don't see these very often, especially on this show, right? I'm honest to God thinking that this is the first one that we've done. But this is a all-paid fire EMS crew, consists of a 3-person ambulance that are all paramagicians.
I think we did a double medic big city fire department one time before.
We've done double medic.
We've never done triple.
Yeah, this is status paramedicus.
This is OG triple OG. Yeah.
So it's 3 times the laziness. What?
That's right.
3. What?
Well, hey, you get
shots fired.
30 compressions with your foot. Then you got to give it a break. Let the other foot get in there.
So, I'm not even gonna. You'll hear my joke.
We gotta get back to that station for the the downtime.
You'll hear my dig that I purposely wrote into this a little bit later. But so being that it's an inner city, huge metropolitan area, there are multiple city hospitals within driving distance. All are similar in capabilities. So I didn't really even ask, like, what's the difference between A and B when I was interviewing for this call. The nearest hospital is going to be a transport time of about 15 minutes. But it says about...
Will they have traffic?
20 minutes with traffic. Yes. So you guys are dispatched. A priority 1 or a Delta priority for those that love the Deltas for an adult male with difficulty breathing. The city ambulance is sent, and while en route is updated that the patient is declining and becoming altered. So my first question, as always, I like to throw one in right off the rip. A respiratory patient who is said to be severe or declining. What red flags does that create in your mind? And what actions are you already thinking about before you even set foot on scene?
Obviously, you're dealing with hypoxia, so this patient's going to be altered and working on, not being alive much longer. Yeah. So you got to start thinking about airway.
Fast airway. Yes. Move fast, right? This is not the time to dilly-dally. It is the time to be aggressive.
I believe there was the moment in time when we looked at the guy who was butt naked, sitting on the toilet with chest retractions, sweating all over the place, eyes bugged out of his head, couldn't breathe, looking straight at us like, oh my God, I'm going to fucking die. And I'm like, okay, well, let me just snag a blood pressure. And then somebody goes, I think we're going to be a little more aggressive.
Yep. Yeah. And that's, I think the way my brain looks at it is like, I'm already creating what this patient is looking like. Like, I'm envisioning their look test in my brain as I'm going there. So that when I actually do walk in and see, like, the blue patient that's half unconscious and barely breathing with a sat in the 50s, you're not, like, scared of it. You just act. Because you've already rehearsed it in your brain, like, this is what they're going to look like before I get there. So these are the actions that I need to do. And yeah, being overly aggressive is what's needed in these situations. And what are your things? What are your thoughts here?
Yeah, I agree. I think you need to, I always tell people like treat for the worst, hope for the best, but you need to have the worst case scenario in your mind, and that's what you need to be rehearsing. Like, I'm walking into this with an airway plan. I'm walking into this thinking that this is going to be the absolute worst case scenario. And I'm not talking about the cardiac arrest because that's an easy one. You just follow an algorithm, but like that's the mindset I'm going into this with.
And I want to just throw it out there so you guys can start thinking, is this is a system that does not have RSI capabilities. So throw that off the table.
Smart doctor.
Right? So toss that
he
right
knows
out
his
the
fireman.
So this is, again, kind of a unique situation in that we have Status Paramedicus. There's no EMT in sight. There's no, like, CFR or anything here. Does anything change in the way you think or prepare when you have 3 paramedics going into this? Like, if you're, the 4 of us go in, or 3 out of the 4 of us go into this situation, like, how does that change the way we navigate through the call?
Well, I would hope that we would already have a plan of division before we get in there, like who's doing what. All right, and the fact that you've got 3, skilled paramedics going in, then I mean that makes life a lot easier as far as the ALS end of things.
Yeah, but that's what you're going to forget is the BLS side of things.
Well, yeah, but my point is going in, like, I'll be like, hey, you're on IV shit. You deal with meds. I'm gonna talk to the whoever, try to figure this shit out, make sure we're not gonna fucking stick something that's allergic or whatever. Like, I'll get all my sample of risky shit, and and just do a quick assessment. Like, one person will assess, the other people get ready to do shit. Take care of the oxygenation. You take care of ventilatory support, whatever. I mean, just basic, like, hey, this is the shit we're gonna do.
I mean, you can almost divide and conquer the ABCs.
Pretty much, yeah.
Each. Hey, you're on airway, you're on breathing, you're on circulation.
Yeah, pretty much. Boom, done.
Yeah, I think division of labor and knowing tasks is kind of the cheat code in this, right? And not forgetting the BLS. That's I think where I stand as, like, it's up here is we have to do those BLS-y things before we get to, as Maha says, the ALS-y things.
I mean, I hope it's different for them if that's like their normal setup. They're used to not having a BLS provider, but like, if I were to show up on a scene and there's 2 paramedics and then I'm coming as a paramedic, like, I'm using my EMT skills way more than I'm using my nursing skills.
Mm-hmm.
I know a bunch of us talked about it before, but like respiratory is like one of the things that we can have a major effect on, like with everything that we have. I mean, other stuff like, a stroke, you throw a 12 lead on and drive them to the hospital fast, but respiratory is like the big thing that we can really
fix,
really change in somebody. Yeah.
Yeah. I mean, they literally could be knocking on respiratory arrest door and you drop them off and they're breathing 20 and unlabored. And you're like, cool. I did something. I actually made a difference.
It's funny because I think we had this discussion when we were talking about, like, I don't remember the episode or whatever, but it was, we were talking about, the metrics that agencies track, for performance numbers and shit like that. And it's like I can't tell you how many, I wish they would track calls like that, like respiratory calls, that, where you get them to the hospital and, now they're sat, they're 120/80, they're satting fantastic and they're breathing just fine.
Right.
And when you got to them, they were like at death's door.
Yeah.
But we don't track that shit, but we should.
Yeah.
Because that's, to me, like, yeah, those are so many times we win that battle.
And I think, tracking that on this sidebar, tracking that has a huge impact on the mental, morale of your crews. Like, hey, they're giving me praise for a call that I just thought was every other day call. But look at this. Management is telling me that I actually made a difference.
Yeah.
That goes a long way You know, way more than, oh, hey, good job on the one baby you delivered over the last 10 years.
Yeah.
Who cares? You know?
Or the 20th cardiac arrest that didn't fucking go right. You know
Exactly.
what I mean?
Yeah, absolutely.
I got Ross. Great. They died 2 days later in the fucking hospital. Who
Right.
cares?
Who cares?
You know?
So, the fire medic arrives, the ambulance arrives on the scene. The providers actually do fairly well, right? You'll notice a trend that these firemen aren't as stupid as we want to assume they are, right?
I joke around, man. They're not all stupid. I mean,
they really aren't.
We've had a few fun, ones that we love to fuck with, but no, I mean, like for the most part, man, they're trying to do the best thing they can do, man.
Absolutely. They grab their monitor, they grab an oxygen bag, and they grab their drug bag. I also have to assume that one of them has a tablet. It wasn't noted, but we have to assume, right? The team enters the home and is met at the door by a younger male, like a middle-aged male, who identifies themselves as the patient's son-in-law. He states that his father-in-law has been sick for the past week, has been running a fever, and was prescribed antibiotics for a lung infection 5 days prior with no improvement. They go on to tell EMS that they are, as they're entering the bedroom, that he has been struggling to breathe since last night, always the case, increasing his home oxygen twice with no improvement. The family came over to check on him this evening and found him in poor condition and then called us or EMS immediately. So before I get out to the primary and actually show you what this gentleman looks like, what sticks out in the brief, quick story that the son-in-law tells? Like, what is this jumps out at me the most?
Like he's on home oxygen, so he already has respiratory
Right.
issues anyway. It's like that's already a thing.
Yes, he's already on home O2. He might be on 2 liters.
This infection could be just,
He's got 5 days of this infection and antibiotics aren't helping. So like,
right. And
Is
it's
he
an
now
extension of
septic?
this.
Yeah,
Yeah.
Right.
probably more viral than it is,
And I don't know why, but we were talking about firemen, and the first thing that popped in my head, literally like 2 seconds after I just was like, "No, man, most of them are pretty good, they do their shit." But the first thing that popped in my head was, "Please, God, don't let these guys have Lasix."
No.
Because I had to show up, and there was a fireman who gave Lasix to somebody with pneumonia.
Awesome.
Fantastic.
Absolutely fantastic.
Yeah.
Yeah,
like, you want a trowel for the cement you just fucking made?
I think, yeah, I think looking at it from the aspect of like, okay, he has an infection that hasn't been getting any improvement. So now is this, an immunological problem? So like, is this sepsis, right? Added on top of all of the other things. The home O2, what was he on before? What is he on now? A home oxygen concentrator only goes up to so much,
Yeah.
right? And
depending on the machine, it's either 5 or 6. So
bingo, right? And what always gets me is it's been worsening since last night, which means they've been already through 12, 24 hours of this, which means I'm already getting them at the end of that Krebs cycle where they're going to be tired. They're going to be lethargic, and they're going to be closer to the, like, oh, hey, I'm just going to, my ventilatory status is just going to kick out on me anytime. And I hate that. Like, that's a pucker factor for me. Like, okay, I have to go in and actually do things in a fairly fast manner, kind of thing. So 2 medics walk up to the patient, while the third stays with the family member to gather a more in-depth history. Divide and conquer.
Nice.
Yep. The primary medic You're going to hear primary, secondary, and then the third paramedic. So primary medic begins their initial assessment and finds that the
Can you
male.
just say tertiary just to keep it.
Nope. Nope.
No.
I did that just to piss you off.
Thank you.
Gotta utilize the correct words.
Yep. Just to piss him off because I know he'll every time I do it.
Just let's just be pacific about everything, okay?
I'm gonna be very pacific.
Thank you.
All right.
Irregardless of how it goes.
What were his stats
Yes.
again?
Yeah, but with the stats.
So the primary medic begins their initial assessment and finds that this male is semi-responsive, very lethargic, and audibly wheezing. Airway is clear of fluid and debris. He is breathing rapidly and shallow. Visible intercostal retractions. There's visible neck muscle use and sternal retractions.
Not good.
Lung sounds are taken, and they are found to be quiet with coarse wheezing in both apices, and quiet to nothing is heard in both bases. Skin is pale in color. He's clammy with no active diaphoresis. No apparent bleeding is noted. Pulses are present, but weak. So we all know, and everyone listening knows that clearly this guy is a serious patient. As we alluded to many times already, aggressive breathing management is our plan, I would think. But what does that look like to you guys with this presentation?
I think we're probably going to be bagging him sooner rather than later. And I know I'm supposed to be thinking BLS, but my first ALS question was, what respiratory drugs does this agency carry? Like, what I don't know where they're at, so I don't know what they have. But I'm already thinking fucking Dex immediately if they have it. Get that going as soon as possible, just because there's nothing down low that's even fucking opening up for anything right now.
Yep.
And then I'm thinking almost like our guy. I'm like, you know what? We'll get the blood pressure later. Let's just get that CPAP prepped and ready to go, and maybe somebody just jump on that bag right now and start to see how deep we can get the air into them. I guess.
Okay.
I mean,
And what about you?
No, I'm with Gerard. I mean, I think you have to be aggressive with this guy. He doesn't have much longer. And I would say in about 45 seconds, you're no longer going to have the option of CPAP. So
yeah.
I think you need to pull, I think you need to have MAG. I think you need to have Epi, like right in the back of your mind, getting ready to give these. Like, I think you need to be aggressive with this.
Yeah.
I would assume Maha agrees with all that. Yeah. And the really interesting thing is, I think depending on where you are as an agency and where you are, like, in the world, in the United States and wherever, some of us are looking at, okay, I have CPAP as an option. I'm quickly losing that option, right? I have a BVM. We all have those. Some of us have BiPAP as an option through the vent. And then we have the RSI capabilities, right? And I would say that, depending on certain things, vital sign resuscitation wise, if I didn't have BiPAP as an option, my immediate thought to this guy is I'm going to tube him in the next 15, 20 minutes, right? He's getting RSI because clearly we're on the downturn.
Yeah, but you said they don't have it.
But they don't have it.
If they had it, that would be the first thing to go to.
Exactly, right? And as we build on the call, I think we're going to see some really interesting things. And that's why I said we'll see the different levels that everybody can look at: CPAP, BiPAP, and RSI. So the secondary medic.
I mean, and honestly, really, like right now, just go. I'm sorry, but I mean, the first thing you could do is just pull somebody off at whatever they're doing and just be like, hook the fucking bag up and just start assisting him until we can get everything else set up and ready to go. You know what I mean? Yep. Buy me another minute.
Yeah. Yeah. I am 100% not against ventilating this guy at all. I think, M is completely correct in that your time frame for CPAP is closing, especially if you don't have the RSI option, which these guys don't. So this is their one blunder, I think, major blunder. And that is we didn't think aggressively enough off the rip. And the secondary medic says, okay, don't worry, I got you. I'm going to set up a duoneb. And they start mixing the albuterol to Atrovent. While the primary medic shouts over to the third medic to get a history that's been gathered. Like, hey, give me what you know. The third medic lets him know that this guy has a history of hypertension, COPD, is a pack and a half smoker a day, who has not yet quit, diagnosed with pneumonia within the last 2 weeks, has no allergies, takes Advair, has a rescue albuterol inhaler, is on losartan and amlodipine. Any questions, thoughts about that?
Sounds about right.
Sounds about standard. Maha, you're kind of crunching the thought process. What's
just
mulling
going through-
over there?
Just going through the drugs in my head, see what
Okay.
we got going on.
Okay. So at this time, the duoneb is placed via a mask and is set to 8 liters of oxygen. Primary medic establishes a successful 20 gauge. Meh, it's access.
Really?
I wish it was bigger, but it's what they all say.
This is what I want to say. Remember we talk about law of primacy all the time?
Yep.
All right. So, riddle me this, Batman.
Here I'm thinking the third is going to get him, and it's the damn IV size that's going to make him go off on.
Fucking A, dude. Fucking paramedic schools. All you fucking teachers out there, instructors, whatever the fuck you want to call yourselves. Yo, stop teaching 20. Teach 18. Let them downgrade to 20 when they feel it's necessary, but think 18 is my standard to go to. It should be your standard. It's been my standard. Once I learned in the field, hey, by the way, 20s are for fucking pediatrics. You know that, right? No, I didn't. They told me to use 20s all the time. Oh, you mean I can just use an 18 whenever I want? Yeah. Hey, guess what? I only used 18s. And I can't tell you the number of fucking nurses that did this shit to me as I fucking tell them what I got in there.
Absolutely. Which is really funny because back me up on this.
That or I'm just like super hot, but not, you know what I mean?
I mean, you are the most popular person on the show.
Yeah.
So, and back me up or just illuminate from the hospital side of things. Why is it that 99% of hospital patients and nurses start 20s?
Because it's a comfort thing for them. When they look, so here's the thing with IVs and nurses. It's not a skill you learn in nursing school. So you show up to your first day on the job and they're like, okay, we're going to do sticks. And your first experience with an IV stick is on a live patient. And you are freaking the fuck out because everybody thinks, oh my God, I have to do this skill. It's a monkey skill. You do it 5 times, you can do it 500 times. It does not matter. So everybody puts a 20 in. And in 2 hours, when you have to access that IV again, or you have to pull something from it, it's not going to work.
Right.
Mm-hmm. Yeah, which is why everyone gets stuck every other 5 hours.
Exactly.
Yeah.
Exactly. Just put the 18. If you can put a 20, you can put an 18.
Bingo.
Yeah.
I've put 18s in grandmas with
Yes.
paper mache skin.
Mm-hmm.
No problem. Once you learn how to do it, you're fine.
Unless you're under the age of 2, I'm putting an 18 in you.
And
That's what it is.
realistically, the size difference on the catheters is not all that different.
But how the blood flow around the catheter, the 20s are 10 times more likely to occlude.
Yep. Yeah, they're also likely to wobble too,
Mm.
and that's just going to create a bigger chance for you to create a blood clot around the end of that catheter.
Yes.
Yeah, it's one of the things that I always teach and always do on every single interfacility transfer. Once I became a paramedic was go in, and this was actually something that Jess told me to do. Once she started flying, She was like, every single time that you go in and take someone out of the hospital to somewhere else and they have a line, make sure it works before you leave.
Yeah.
Yep.
And because I never, you don't learn that in paramagician school.
I learned that the hard way.
Yeah, I couldn't tell you. I got lucky until she told me that, and now every single time I go in, I grab a flush, I make sure it flushes, I make sure it flushes back in, it draws, it flushes, it's good. Okay, let's go. But yeah, it's like you got to worry about that kind of stuff. So successful 20, right forearm. Decadron, 10 milligrams, is given via an IV push. So right now, as it is, they are moving steadily, step by step.
They're following their protocol step by step when they probably should have skipped a few steps.
Aha, yes. So they recheck his responsiveness. He lifts his head to painful stimuli. But this time he keeps his eyes open, although he still appears tired. They decide to move him to the stair chair at this time. The first duo neb is finishing. They remove it and recheck lung sounds. They still hear quiet and coarse wheezing in both apices, with more absent lung sounds in the bases. So before we move on,
so they waited on scene to do the entire duo neb.
Correct. Yep. Yeah. So you got 8 to 10-ish minutes, depending on how fast this guy and efficiently they were actually breathing.
It must have been later in the night after dinner.
Probably wasn't a football game on. They're probably, they might have stopped for Chick-fil-A earlier in the day. You never know.
The stinky fireman that doesn't shower is probably at the station that night.
Chicago Fire wasn't on that night.
That's right. Rescue Me or whatever.
They already watched Backdraft. Yeah.
The knobs have all been polished.
Right.
So in a twofold question here. What is your guys' kind of changing impression of this patient at this point? We've seen some changes, some good, some bad. And then knowing that they're following this protocol, kind of a step-by-step, where do they need to be once they actually get inside the ambulance? Because now they're going to move him outside.
And he's got
They should be begging him right now.
So he went from nothing to coarse crackles, and as soon as he hits that cold air, he's going to flash on him. Have a good day.
Is this the winter during flu season?
So I honestly don't know what time of year it is, but knowing where the city is located, you don't really have to worry about cold air. So there's that. I
thought the same thing until I went outside this morning. It was 32 fucking degrees.
Oh my baby.
32.
Oh my God.
We had
We're completely fucked. We're completely
When's the snow falling, Gerard?
We had frost.
Oh,
It was It was frost. When I started the truck, it took like 5 minutes for it all to melt.
Holy.
Yeah, he says to me, he goes, my ground was white this morning. I was like, yeah, mine is still white this morning.
Right. I had to plow again today because it became more white. When I was plowing, it was 16 degrees outside, and I was like, "Oh, it's a little ballsy out here."
I mean, to be fair, thank you. It did. But when I got on site, it was like 45. So like, I was all right.
It's all right.
Sun was shining.
Day was 30.
Right?
Yeah.
I'm pretty sure it's 13 degrees right now.
Gotta love it.
Oof.
Yeah, I'm thinking it's supposed to get down around 9, 7, somewhere around there for me.
We're supposed to be 20. I think 29 tonight.
Oh, man, better like pack the pipes. They might burst.
But I think tomorrow's high is gonna. It's 50 tomorrow. Okay, we're good. Be all right.
Wind chill of 16.
Yeah, yeah. We have a sun chill of like 20. Goes up it goes up, not down. Anyway,
unreal.
why aren't we at least bagging this guy? I guess is my question.
Because the magic duo neb's supposed to fix him.
But you can magic
Yes.
dual neb through the fucking bag. I heard about that.
You can.
Works a lot better through CPAP if they put it on earlier.
It does.
I mean,
I heard about that too.
Yep.
Oh.
M, you look scathing right now.
Oh,
You're just,
I mean,
piercing through the.
I mean, I hope that they're running through their ACLS algorithms because that's what this is going to be. But yeah, I mean, I think they need to be more aggressive. The duo neb, like if that's what you want to waste your time on, first of all, one at a time. No, thank you.
Yeah.
No. But I think that was a waste of time.
But I mean, again, like how, what is the corporate culture of this system where, I know coming out of school and all that, you hit the street and you stick with your fucking protocol, you run your protocol. And then it's not until you're out there and you have other people who are seasoned who go, yeah, they're more like guidelines. Like
Right.
if you need to go from A to fucking F to keep this motherfucker from becoming dead, then go to A to F and then figure it out later.
Right.
But fucking do what you got to do.
Or I don't know, start at F and eventually
Whatever you got to
yeah.
do, whatever you got to do.
Yeah.
But within those guidelines, do that shit.
Right.
You want to go outside the guidelines, make a call. But
And I think-
somewhere in there, just do it.
It's funny to me that they prioritize giving decks, which like is a great call, but in reality, you're never going to see the outcome of that. So like, it's interesting to me that that's what they prioritize when you will never see the outcome of that med.
Which I was going to bring up later, M. So thank you for that. Right, onset for like peak onset
45 minutes.
for Dex at the least is 30 minutes.
Yeah.
So you're not going to get any help from that anti-inflammatory steroid until they're already in the ER.
And like I do think
still
that
better than Salumedrol.
I mean,
Yeah,
that's
so-
true. That is a fact right there.
But
See,
there's some more effective drugs that we had in our bag besides Dex that can help this guy right now.
right, like I think you need to get the fast acting ones on now because you don't have an option if he gets any worse, and then kind of backtrack. Like, yeah, the ear's gonna love you if you give the dex, but it ain't gonna help you at all.
And that's
I mean, pretty soon to be doing epi, just the wrong kind.
Well, one of the things I used to do, and it just became automatic with me when it came to Dex, was I got a respiratory, and depending if it's if it's manageable respiratory, yeah, I know it's not gonna be working right away, but especially when you have something where you don't hear anything in the bases, I draw that shit right the fuck up, and then open your mouth, squirt it right in their fucking mouth. And then move on and do everything else I want to do, because I already know that's on board. And as I'm doing everything else and we're transporting, it's going to do what it's got to do. I'm not going to waste time with the IV drawing up, but fuck all that. Just squirt it in their fucking mouth and then go back to doing respiratory shit.
and realistically, you can do PO Dex, right? I've done the exact same thing. Like I used to do it all the time when I would put somebody on CPAP. I would be like, "Hey, open your mouth."
Bring
And
that
then,
real quick.
here you go. And then I wouldn't have to break the seal anymore, when, because you're already thinking, okay, I have 3 options to be able to give Dex. I can give it IM, IV, or PO, right? PO is slow because they're in sympathetic overload, so their gut's not working as well anyway, right? But neither is the vasculature in their arm muscle or leg muscle either. So even if maybe I don't have the statistics and the data in front of me, but I'm sure that IM is still faster than PO, right? But by how much?
And how much time are you wasting prepping for it?
Right. And
Well, PO on a normal human is going to take like an hour to an hour and a half, like the peak.
right.
Yeah. Again, this is a down the road med anyway,
Right,
so it's
exactly. This
And I
doesn't
think-
make a difference to me.
right.
And I think that's the big discussion hammer home point that I think we have to get our listeners to understand is that you are giving Decadron not for results now, but for results later. And it's not this like, oh my God, I'm going to give a steroid and magically they're going to get better in 10 minutes.
So I'll give you a perfect example to drive home your point. When I started switching to doing it, just shooting the PO and then forget about it, and I move on to do everything else. Those were the ones that we just talked about, where when I'm walking them into the freaking ER at the end of the transport, they're fucking satting perfect, they're breathing normal, their color's back, their blood pressure's fine, and they're fucking perfect.
Mm-hmm.
It didn't fix them. What it did was all the other shit that I've been doing the whole fucking way in, when it starts to kick in, it's going to help all that shit.
Right.
So yeah, when you finally get there after your half hour, 45 minute, hour long transport, I mean, for me, it was always, a freaking distance. So I had to think differently. These guys are 15 minutes to a freaking ER. Don't even fucking worry about it.
Right.
Think, fuck it. Let them push whatever they want to push at the hospital.
Yeah. Yeah. And it's like, I like to think about Dex as almost like extra credit.
Yeah.
Right? You're doing it, but the extra credit points don't come until later.
Yeah.
Right? And you're not going to get that result immediately. Maybe if you have a long transport time, you might start seeing some really good effects of it in an hour. In a city environment where you got 10-minute, 7-minute, 15-minute transports at most, what is the point? Right? Yeah. You'll see it 45 minutes after you leave,
We used to have a really fun bronchodilator that we used to give people. I'm just going to show my age here, but terbutaline used to be in our box.
I can't say I ever worked in a system with terbutaline. It. Nope.
Oh, because they got rid of it in like 2010, 2011. When that rollout went out, they got rid of it.
Oh, wow.
Wasn't it?
What's that?
Terbutaline went away before that, didn't it?
I mean, out of our protocols. I think it was gone. Like we had it for a while, and then it was gone. But yeah, it was.
I thought it went away
well.
in like 06, 07.
I was going to say, I came in 07, and I don't remember any of the medics carrying terbutaline.
It was really, but yeah, it used to used to work well until people gave it to the elderly and blowing out kidneys.
Yeah,
those are bad things.
He blows out a kidney, it's fine.
Yeah, who needs?
At least you're breathing.
I was gonna say, I mean, what's more important,
Right.
I mean, last time I heard K is nowhere near A, B, or C. Fuck all that.
I mean,
you don't need that
fair.
kidney. Piss later. Piss on your time. All right. So and this is my time down here.
They remove him from the house. Again, foul up number 2, without any oxygen assistance in
Are you fucking kidding me?
At all.
They can't carry on the stair chair, so
they can't carry it on the stair chair.
Straps.
To be fair.
Thank
you. They didn't make him walk. It's fire department.
Woo! Yeah, I gotta give that.
They use the stair chair.
The ABCs. A, B, can you walk?
Right.
That's true. So no oxygen at all in place. They move him to the stretcher and then into the ambulance. Third medic moves him, connects him to the cardiac monitor, and finally obtains the initial set of vitals. The initial rhythm they see on the monitor is a sinus arrhythmia. It's tachy with unifocal PVCs. BP 169.
Not shocked.
Nope. None of this.
I can tell you why you're seeing those PVCs too.
Right. BP via the auto cuff is 169/99. Heart rate 131 on the monitor. It's weak and irregular. When I had to be honest, when I was,
it's about to be really irregular.
Right, it's gonna be a lot of squiggly.
And eventually it's going to be the most regular rhythm we have.
And the most stable.
The most stable, regular rhythm you will ever see.
So you know how we always make fun of like vitals of the day, right?
Oh, yeah.
120 over 80,
Yeah,
75, 18. They gave me this respiratory rate in the Google form, and I was like, bullshit. Do I have a bullshit calculator? Because
Make it 16.
no, 30 shallow and labored. And I was like, for the way this guy is breathing, there ain't no way that it's 30. Like, ain't no way.
Yeah,
They're probably guesstimating.
That's kind of what I'm thinking.
What did you say, Emily?
he's pooping out. He's
Yeah.
on the downtrend of 30.
Yeah,
Right. Yeah.
You're right. You were absolutely
Absolutely.
right. No, it probably was 30 because it was 50
Probably
before.
was. He's about to take his last breath.
He's probably about 9 right now.
Right, we're getting close to 1.
Getting close to-
SPO2,
Oh.
SPO2 of 82 currently on room air.
They didn't
Fuck,
dude.
put him on his home oxygen. Nothing. They just took him off.
Nope, took him right off. They don't
Wow.
need it.
It's probably pretty good for that then.
Hey, oxygen
cord
is
wasn't
expensive
long
these
enough.
days. It's like, $8 for a huge medical M cylinder tank. It's expensive.
I
I
mean,
feel like 82 is good at that point.
I got a feeling these guys, like, they don't really, like, when they go fishing, they just let the fish flop around on the fucking deck until it stops moving. You know what I mean? They don't put it in the
it'll-
cooler. They don't
it'll
try to
stop
freaking put it out of
eventually.
its misery. They just let something flop. It'll be all right.
They don't beat it with a stick.
Yeah,
So the secondary medic, doing nothing at this point, mixes a mag drip, into a 100 ml bag. Drip is infused over 5 or so minutes. The primary medic moves to place him on CPAP.
I was just about to say, we've done all this fucking ALS high level fucking drug shit, but nobody's done the
Wait.
one mechanical thing to actually fix the problem.
Nope.
We're a bit late
Nope.
in this.
Yeah.
We're following the thing. Even though, I mean, granted,
CPAP was here. We're about
CPAP's
here.
up here. We're
If
down
I'm-
here.
If I may use one of my favorite analogies from my previous life, it's like wiping your ass then taking a shit.
Yeah. Can't get any clearer than that one.
Pretty much.
He's still awake.
He is still somehow still awake.
That's he's going like this.
That is
He's
a
like,
valid question.
He's dead.
Right.
gasping. But his eyes
Remember
are
that fish we were
spontaneous.
talking about?
I mean, those agonal breaths, they're breaths. It's in the name. It says breaths. They're fine.
Yeah.
So the medic secures CPAP to his face, sets him on 15 liters oxygen.
And he's coherent enough to have that and tolerate it? Okay.
So
Sure.
the guy was not very verbal at this point, but eyes were still
Okay.
open.
Was somebody holding
Jesus right
his
now.
head with his eyes open like that?
I mean, he might be Weekend at Bernie's a little bit.
Yeah.
They might have.
Hey, he's Chinese. Oh.
They set him at 15 liters oxygen, and they place the dial, the PEEP dial,
PEEP.
to 7.5 centimeters of water.
Because that's what they're
PEEP.
taught. Yep.
At least it wasn't set at 5. All right, we're gonna get into that.
At least they didn't make him walk. At least it wasn't set at 5. At least.
It's okay. You start somewhere and adjust.
That's right.
If they adjust that, I won't even give them shit about starting it there.
Okay.
There you go.
No, okay.
So once the mask is secured and running, another duo neb is placed in line to the CPAP and run in at 6 liters oxygen.
Yeah.
Third medic at this point gets out of the back of the rig and begins transport to the hospital. Like I said, transport time is roughly 12 to 15 minutes with some city traffic. Lung sounds are retaken again by the secondary medic. Apices are still coarse, but very, very slightly louder wheezes. Bases are still really quiet. At this point in time, they reach the bottom of their protocol, and finally, the two medics have a discussion over the option of epinephrine. The primary medic agrees
Shouldn't even
that
be
they
an option right now.
right.
We're not discussing this. We're doing this.
Yes.
Right.
Right. It should have been done 20 minutes ago.
No, they don't want to give it because the heart rate's 130. Come on.
It's like you guys.
Would it be better when the
online.
heart rate gets to 0?
Yes.
So
Yeah.
wait. They don't want to do the epi at 130, but we'll give a couple doing those because
Right.
Right, because
They
that's
don't
not.
realize that.
albuterol never affects the heart rate.
Protocol. They're doing the best they can, guys. They're doing the best they can.
Alpha, beta reset. What the hell?
I mean,
We
they
don't even
didn't
know what those are. Maha.
They didn't just throw them in and fucking run with the only treatment plan being to tell the nurse that, well, we were just 5 minutes away.
You're right down the road.
Yep.
They re-listened to lung sounds.
Three times.
Now, this is the third time.
Yeah.
This is tier 1 level fire EMS. This is fire EMS at its finest.
Listen, they're doing
They
okay.
need
They're
They
doing
need a
great.
TV
Doing
show.
okay.
They
Yeah.
should have it. So when do they pop open the big pen and fucking jam it in his fucking throat? And then, to balance it out, shove the avocado up his ass. You know what
That's
I mean?
right. It's got to be bihemispheric.
That's
all right. And if you
So we're gonna apply pressure to the vagal nerve.
if you
All I got is
stick,
an avocado.
if you stick the oxygen tubing through the avocado,
there you go.
it's then flavored oxygen.
It's a superfood.
It's a superfood.
All right.
So, the primary medic in this discussion agrees that they should give the epi, but is concerned with the heart rate.
Hey, motherfucker.
So they decide in their 12-minute transport to waste another couple minutes calling their agency medical director. In this system, they don't just call the hospital for a med direction. They actually call their physical med director of their agency.
Big budget.
Yes.
Big budget.
One
Yes.
of Doc's first words, "Are you idiots?"
Just do it.
So I guess my question is it in their fucking standing orders to do it? And if so, just fucking do it.
So I did have to scour the internet and find the city protocols, like the area protocols, and it is in their protocol as a standing order to give 0.3 mgs of epinephrine, just like New York.
Then we need to have a sound effect of somebody slapping a piece of meat, and we call that the pee-pee slap.
That I don't have, but I do have this one.
You absolutely suck!
So the phone call is made. The agency medical director literally just goes, "Yeah, give it." But they say give a higher dose. They say 0.5 milligrams. IM epi. Go right ahead. So
Doctor says
that's what they do. Now, I want you guys to table the answers to this until later. Yes, sir.
Question:
Yes, sir.
Was racemic epi ever discussed?
No.
Okay.
Nope. Again, I want you to table the answer to this until a little later. We're gonna have a discussion between CPAP and BiPAP. So I'm gonna ask you now, for this patient, would you have chosen CPAP or BiPAP? And I just want you to mull that over. Don't answer me yet. We'll get to it. But I'm giving you the forewarning. Another set of vitals is spit out as the IM dose of epinephrine is given. BP drops a little, 149/96. Heart rate, 126. A little bit stronger, but not much. Still sinus arrhythmia with PVCs. Respiratory rate, because they spent their money and they actually put this guy on end tidal, it is counted at 46 shallow and labored. SpO2 of 89 on the 15 liters via the CPAP.
That waveform could help you make that BiPAP decision.
Right? And end tidal spits out at 26. So due to the short transport time, there's no more treatments given. The only change was to the PEEP setting on the CPAP. It was moved from 7.5 to 10 centimeters of
See?
water.
I knew I could count on them. I don't care where you start as long as you adjust.
There you go.
I knew I could count on them.
Woo woo.
Right.
And lung sounds had loud wheezes in the apices with barely hearable. I know that's a made up word. Barely hearable wheezes in the
Audible would be
bases.
more
Nope,
educated,
I'm
but
going
okay.
with hearable. Shush your mouth.
barely auscultated.
Auscultation. I have auscultation.
Um,
Yes.
The crew arrives at the hospital, unloads their patient with the full report. At the time of transfer, end tidal remained in the mid-20s. Respiratory rate dropped to the mid to high 30s. Less labored, but still difficult. SpO2 ended at 91. Mental status remained the same. He was able to nod, but not really speak, still appearing lethargic and tired. So, how'd we do overall, guys? I think, honestly, hold on. It's a concept of this show to make fun of firemen.
I'll say
I want all the firemen to know that we actually do love them and respect what they do. You just make it so damn easy to.
I mean, I could say the biggest cliche phrase there is a lot of my friends are firemen.
Right, absolutely. I don't have a lot of fireman friends, but I think that they, taking fire EMS out of it, right? They're 2 EM or 3 EMS providers from a high level agency, all paramagicians, whatever. I don't think that they did any better or worse than any other provider we have ever reviewed.
I was just going to say they got the patient there better than when they got them.
Yeah, I agree.
Right. And I think
it's kind of the job.
And I think once we talk about, the CPAP versus BiPAP and, pharmacological things that I
Oh, you got that word out really good.
I'm on my second, and maybe that's why I haven't had to hit my buzzer button yet. But now that I said it, it's coming.
Free drink Mike is where it all goes downhill.
Right? It's normal Mike is when it goes down.
Suddenly he becomes a grand order around drink 4.
Yep. You would know.
The great communicator.
So, yeah, I think, in my opinion, I don't think they did better or worse. I think there was adjustments that they could have made that would have maybe increased their success rate higher than where it was.
They could have done better.
Right.
But more aggressive.
But yeah, exactly. They didn't shit the bed.
No, and I think, they are where so many providers and, full bore honesty here, myself included when I was a brandy dandy new paramedic.
And a not so new paramedic.
And not so new
I distinctly remember one call.
I know.
Hey,
I know,
we need to fucking
happens.
RSI right now. Well, hold on now. We got to do some other things.
That wasn't recent.
Five minutes later.
7 years ago.
5 minutes later, it was, I think we got RSI. Like, no shit, Sherlock.
And it was a great teaching moment, Gerard.
It was.
I appreciate it. It was wonderful.
Yes.
But no, I think being aggressive is something that not only is a cultural teaching, your agency has to teach it. You have to embrace it and run with it and train as being aggressive. Like, I come home and I tell a story to my wife and she's like, well, why didn't you do this? And I'm like, because they didn't need it. And she's like, but they did. And she's like, I would have done it. And then we get to talking and it's like, oh yeah, if I was overly aggressive to the point where she is taught,
Yeah.
it makes sense. Right. And I really love those types of dialogue where like her and I can have that in where she's overly aggressive and I am not. So we have a middle ground. It's like, okay, I could step up to being overly aggressive, but at the same time, if she got in my shoes, she'd have to step down and be like, hey, you can be slightly less aggressive and still have good outcomes. Again, as we'll see. But what do you guys think? Maha, what are your overall thoughts on this?
I mean, yeah, they improved the patient, but they could have improved him more had they been more aggressive when they started. I think they missed a lot of cues when they first walked in, but they finally did the right thing. They just, personal experience, they did it in the wrong order.
Right. Yeah, I agree. M?
I think they did good. I think that, like you alluded to, that it's a cultural thing. If you're used to working in the city where all your transports are less than 20 minutes, like how many times do you make it to the end of your protocol? So I think they did really good about adjusting the things that they needed to. Yeah, we all would love to see them be more aggressive, and I agree with that. But like, what I hope is that at the end of this call, that they won't do this exact call the same way the next time. Like, all you can ask is that they improve from the next time, right? Like they hit all their check boxes, the patient got delivered better, kudos for that. Just, on the next one, like see if it changes your practice at all.
And I think you hit a huge point. I didn't even think about it. Transfer times and not even making it to the end of their protocols.
End of that protocol ever.
Right. Like maybe this is the first time they've ever made it to mag and epi, and that's why it wasn't on the forefront of their brain, because every other time it's 7 minutes to the freaking ER.
Exactly. So thinking with that, if you had been told that this was a brandy dandy new medic in the beginning, would you have given them a little more leeway? Like maybe, So I think that this call is what it is, and it went. I mean, like you said, they delivered the patient better than when they got there. The important part is like, how do you do it the next time?
Right.
And again, yeah, I guess the whole, everything's relative because I mean, like my mindset is always, and I mean from the day, the day I stepped out of EMT class to the day I stepped out of freaking paramedic class, my brain always had to be geared for long transports. Like I'm picking somebody up in the middle of the fucking nowhere and we're going to a hospital that's nowhere near where we're at. So my mindset is a little different than someone who has 3 hospitals within, 15 minutes of each other.
Right.
And it's like, you can take your pick, whichever one you're closer to, just go to that. And here I'm like, my brain is always wired for, no, get this on board quickly, right? Because what did I learn? Yeah, shoot that freaking Dex in early, forget about it, get to the rest of your shit. And then it's going to start working by the time I get there. Well, these guys don't have to worry about that,
Yeah. And
so, yeah. It's a completely different mindset
and
altogether.
Again, I think perspective like opens up a whole new world of conversation, because it reminds me of a conversation and ultimately a demonstration that made me go, okay, I'm not as cool as you. I thank you. I worked the same agency as my father-in-law for a little while, and there was a nursing home that was about 5 miles away from the nearest hospital, and it was like a 9-minute transfer, 7 to 9 minute transfer. And we had, I had just become a paramedic, maybe like 3 months in, and him and I get paired together, and I'm freaking the fuck out. And we end up doing a call there, and he's like, okay, so what do you want to do? And I'm like, I don't know, I only got like 8 minutes. What is there to do? Like I can't do, and it was a septic patient from a respiratory infection. And I was going to be like, okay, I'm going to hang some fluid, start a line, do my, stuff, and then we're going to be at the hospital, right? And maybe I'll get the person's pressure from, 70 to 80 and call it a day. And he's like, that's it? And I'm like, that's all you can do. He's like, go drive. Okay, I'll go drive. And I drive the 9 minutes to the hospital. I open the doors in the back. This man, EKG, 12 lead, 2 large bore IVs, a bag and a half of fluid in, and he's mixing a Levofed drip. And in 8 minutes, I'm like, all right, cool. I have a lot to learn. I get it. I suck at life. You're better. But it does, like, it puts into perspective of what you can do in the limited amount of time that you have if you're focused
Aggressive.
on being aggressive, right? Yeah. He comes from the overly aggressive nature, 25 plus years of being overly aggressive. That was normal. Where I'm just learning, like, oh, okay, I only have time to do this. And he blasted that right out of the water. So, yeah, I think it circles back all the way to how aggressive are we trained to be, So this person ultimately had a significant COPD exacerbation caused from the long-lasting pneumonia, right? The untreated, not untreated, but not getting better pneumonia. So before we go into like CPAP, BiPAP, and that kind of differentiation, remember BLS, ALS providers. Remember what COPD actually is, right? Chronic obstructive pulmonary disorder, chronic bronchitis, chronic emphysema. Right? Bronchitis, you're inflamed, inflammation of the airways, the actual bronchi, with that overly excessive mucus production. Emphysema, destruction of surfactant. The actual cell that is being destroyed, when you really zoom in, is the type 2 pneumocytes. Those are the cells on the alveolar wall that create the protein lipid called surfactant. So as these are getting destroyed, your alveoli lose the protein that actually helps keep the balloon open. Common in smokers. This guy, we said, pack and a half a day, long-standing history of smoking. So, when we talk CPAP versus BiPAP, right, both are considered non-invasive positive pressure ventilation. The CPAP, continuous positive airway pressure, right, super popular within the EMS realm. Both ALS and now BLS providers in a lot of areas can give CPAP, mostly for asthma, COPD, and pulmonary edema. New York State, in the last update, also put it in for like smoke inhalation and breathing in toxic gases. This is straight PEEP with oxygen delivery. All right. To understand the conversations that we're going to have, we have to understand what PEEP is. Right? Positive end expiratory pressure is what PEEP stands for. This is the amount of pressure that's left inside the alveoli at the end of exhalation so that we keep them open. With that and surfactant, boom, your alveoli stay open, and now guess what? Nice little oxygen gas exchange. Beautiful. That's what we like. Normal PEEP is anywhere measured from 3 to 5 centimeters of water. That's going to come in as we talk about constricting airways and reactive airway diseases. BiPAP. Not as common. BiPAP is bilevel positive airway pressure. Most often we're seeing these in specialized critical care units, or ALS trucks that have the capability of a vent. There is a disposable non-vent version. However, from the research that I did, it is not a very popular option as of yet. So we have to have a ventilator on our truck to be able to run BiPAP successfully. Do you guys, before we get into a lot of the differences and positive negatives of both, what are you guys thinking for this patient? If you had CPAP and BiPAP, where are you going with that for this guy?
I'm going to defer to the critical care people here because I've only worked one place where I actually had a ventilator that had BiPAP, but we never used that function. I know what it's for. I know how to set it up and how to make it work, but I'm going to, like, those two have far more experience with freaking critical care shit than I do.
Typically for this patient, or are you talking in general?
Let's go in general and then for this patient.
My answer is the same for both. I probably would have put this patient on BiPAP. Specifically for this patient, BiPAP is easier to breathe again. So because he was already tired, he's already using accessory muscles, and he's already altered, he's pooped. When you're talking about CPAP, the air that you're getting in, which is the benefit of CPAP, is the same pressure that you have to breathe out against. And if I'm tired because I haven't been able to breathe for 14 hours, that is going to make me more tired. So not only am I not exhaling all that great, but I also have to work against that, where BiPAP, it's biphasic. So you're getting two pressures. So you have a high pressure, low pressure. You're only breathing out against the low pressure. So it gives you a little bit of a break. It's a little bit easier to tolerate on the patients.
Yeah,
Absolutely.
and they had this guy on CPAP with like 15 liters. I mean, that's a lot of pressure.
That's a lot of
pressure.
Yeah, I was like, did anybody read the fucking packaging?
Yeah, you could do like a 15, even if he needs all of that support, you could do like a 15/7.
Right.
And he only has to breathe out against that 7 millimeters. Like, I don't know. I prefer BiPAP. I think that most people go to CPAP. That's what they give BLS providers in New York because it's more available, but it's also easier to understand. I'm not setting two pressures, so I don't really need to know what both pressures mean. I don't need to know what the difference between the two pressures mean. I just need to set it for a pressure and go.
Right.
It depends on your transport vent too, because some vents handle BiPAP, CPAP differently than other vents. I mean, the LTVs, 1200s, they're not my favorite to put people on BiPAP with. I mean, you can do it, but it's not
comfortable
very
for your patients.
Yeah, the Revell we had was pretty simple.
Yeah.
You get the Hamilton. Yeah.
Well,
That thing
I
was-
mean,
Random
thing-
caddies.
If you're decompensating on BiPAP to the point that you're like, or they need support that they're getting closer, because once you match those two pressures, you're on CPAP. I don't really need to change the function. I just put them as matching pressures and go. So like, I still have the option to do that, but I can give them a break if if they tolerate it. So that's also why I like BiPAP.
Agreed. So, Emily alluded to the major humongous difference between CPAP and BiPAP is one constant pressure with CPAP. Every inhalation, every exhalation is against the same pressure. So it might be easy on the way in, but it's hard on the way out, making your tired patient work harder. But, it is really good for recruitment and oxygenation, right? If you need to increase somebody's SAT and they're ventilating fine, I might choose CPAP, right? Whereas BiPAP, you have, we're going to get a lot of PAPs here, but you have your inhalation pressure, which is your IPAP, and your exhalation pressure or your EPAP, right? It's higher on inhalation and then it drops so that you get the force of the breath in, but then you don't have to breathe against the force out. So it's easier for your patient to breathe, right? The cool thing is you can manipulate BiPAP to work for oxygenation. That's your EPAP, right? But it's really good for someone who has really bad ventilatory status because you're not making it harder for them. So like people that need bigger tidal volumes, people that need to blow off a lot of CO2, people that are tired, you might choose BiPAP over CPAP, right? So the let's see. Okay, so the big thing that like when you're looking at, you know, CPAP, most of the time it is you're on your vent, it gives you a pressure, and that's your PEEP, right? Because it's straight PEEP. So these guys, they have that dial on the front,
Right.
just like all EMS providers have, which is 5, 7.5, and 10, right? And we don't want to get into like significantly higher pressures past 10, at least at the EMS realm. 5 is normal. 3 to 5 is normal. 7.5 is a nice little boost, making those alveoli spread a little bit bigger balloon, bigger surface area, more oxygenation. That's how we increase the SAT. The biggest thing that we have to worry about, and I want to hear your guys' opinions on this, because I'm kind of in the, like, I'm willing to push the envelope if I don't see certain things. PEEP in a patient with significant reactive airway diseases, like COPD, right? Typically, they're going to be air trapping. Their ventilatory status isn't going to be that great. Their CO2 load might be really high. And if I increase PEEP, I'm just going to create ability for them to trap more air. But if I keep the PEEP lower, I don't inflate those balloons as much, and I treat aggressively pharmacologically so I can open them up, and then I'll increase PEEP. That's what I would do for this type of patient. What about you guys?
Yes.
Does that like?
Yeah. Yeah.
That's
'cause-
exactly what I would do.
yeah.
Like-
I think if you're just increasing PEEP alone, you're gonna blow out the chest.
right. Yeah.
Right.
You need to give them a chance to get that
He's
out.
already got shoe leather in there. It's along with everything else. Yeah. It's
Especially-
The barotrauma is going to be
right.
And one of the things that I would say that I never really had even seen until I started flying was like, if they're tubed or if they're not, like you do virtually a chest compression
Yep.
to decompress their chest,
Yes.
exhale for them, and start over. Here we go. Fresh start.
Me and Gerard did that.
Yeah, it
And
was.
the only reason I ever did that was because my wife came home and was like, yeah, if they are, you know, a reactive airway disease and
Right.
chest is huge and they're, you know, you're trying to ventilate them and they're,
Push.
you know, their freaking
Yeah.
end
it's
tidal is like
wild how it works.
90.
Yeah.
You literally go push their chest, and next thing you know, their end tidal will drop 30
Yeah.
points, and you're like, whoa. The first time I did it, I was with Gerard on an RSI.
Yeah.
And I was like, dude, it dropped like 27 points.
Right,
That's
yeah,
the
yeah.
coolest thing ever.
Right.
We did it on a asthma arrest. And you like just disconnect the vet and you just push on it. I was like, I can't believe that just worked.
Right.
Yeah.
Right.
It is the coolest thing.
But you do, I mean, you can't, it's not a one street for treatment for these. Like you
Right.
have to use meds and you have to use your ventilator or, you know, manipulate
Whatever.
ventilation somehow. Like you can't just increase the PEEP and call it a day. I would love to do that. And, you know, there's a ton of patients that you can do that with, but these are not the ones.
Right.
Agreed.
So I will just show a little visual aid here. You're not going to see them inflated, but this was back when some training was actually performed.
Ooh.
Those
Or pig
are
lungs.
pig lungs that Mac brought in.
Nice.
And he demonstrated PEEP
Mm-hmm.
for all of us geniuses who've never seen what it looks like on the inside. And I can tell you straight up, once you see it visually, the inflation and then just the constant inflation of those uh
Alveoli.
membranes, yeah.
Yep.
It's like holy shit. We should be doing this all the fucking time. You know what I mean? It's like this is
your
fantastic.
regular lungs expand, contract, but
Yeah.
you put that PEEP on there, they expand and they kind of hold
Yeah.
out a little bit, and they kind of
Right.
Yeah,
Yeah,
we'd be bagging, and they would come back, and they would stay right there, and then go back, and then they would come back. Which
And
again, for
if you remember,
COPD, not so good.
if you turn the PEEP on and then your first 5 breaths, like by the 5th breath, the lungs were almost doubled. Like the recruitment
Right.
on with PEEP is wild.
Yeah.
Yeah.
But you have a natural PEEP of 5. A normal healthy human is what? What did you say? 3 to 5?
3 to 5.
3 to
yeah.
5.
I remember
Yeah.
at 5, yeah. So like when that is messed up, now you need to worry about that.
Mm-hmm.
Agreed. And I think the other big reminder that I want people to take away from this episode is be aggressive with freaking epinephrine. All right?
Especially if you have it now.
Yes, this
Because we didn't have it for a long time.
right.
In fact, you got it after I left.
Uh,
I didn't have it.
no.
What?
No. I didn't have it when I was there.
Yes, you did.
It was a physician order. It was not where you could just up and do it yourself.
Yeah, for like
We did not have it.
That was it.
We had it for anaphylaxis, but that was
Right.
it.
Yeah.
Yeah.
So,
Yeah.
be
I remember
aggressive
calling
with
the med asking if I could mix up a little inhalation. And they were like, no, we
Yeah, we don't do that. We only do that with kids, and maybe then
I was like, all
it's
right,
even
whatever,
not.
man. I was like, whatever.
Yep. So this call was literally the perfect opportunity, perfect storm to start with epi, right? Walk in, see that, and go, oh crap, poof, right in the arm, right?
Mm.
Epinephrine is a sympathomimetic. It does the exact same thing as your sympathetic nervous system, right? Your fight or flight. So it's going to activate those beta 2 channels in your lungs, cause the bronchodilation, which is what we want, but not through the lungs. So if you walk in, your patient is this bad, they're sats in the toilet, you can't hear any of their bases, we have to be able to inhale those nebs to the bronchioles that are already closed, right? If you can't hear the bronchioles, it means they're closed. They have shut for business. Nothing is getting through. So all of those neb meds that you're trying to get in are going nowhere. That's why the apices got fixed, but the bases never did until they gave the epi. Because the epi goes through the bloodstream. So it's going to hit those capillary beds and go through the alveoli and all of the capillary beds that surround the bronchioles and open them up that way, right? So in this case, I think hit them with the hit them with the epinephrine right off the rip. In my case, I would go directly to BiPAP and then next go into the mag with the nebs in line with the BiPAP. That probably would have been my choice of action within the house. Then move them outside. Agree, disagree?
Yeah.
Yeah. Anything you guys want to add as we're nearing the end here?
They did all right.
They did all right. Like I said, I can't nix them
It's
too
not
much.
thrilling, but all right.
It was I. Agreed. It was I.
For a fire department, they did good.
Oh, gotta throw in one little.
For the fire department, they should have a parade and make a new calendar, and
Here we go.
you know,
Here we go.
extra shower circle time. You know.
Oh,
They'll have a new ambulance next week.
Yeah. Oh yeah. Yeah.
Got to put that Q on there with the rumblers.
That's right.
Oh my God.
Pinwheel lights on it now. Yeah, that's fantastic.
Uh-huh. Yep. So I think I think the only way that we can end this brilliant fire paramedic episode is, Gerard, give me some form of fire donuts. Just throw it out there.
All right. Smoothbore deuce and a half donuts.
There we go. There we go.
All right. That's where we're going to have to leave it for this episode. If you got something out of this, education, validation, or just a comforting reminder that you're not the only one dealing with this nonsense, do us a favor and follow or subscribe so you don't miss what's coming next. And don't stop here. Go queue up another episode. There's a good chance we already said something that will either make you better or make you mad enough to think about it on your next shift. This has been the Medic Materials Podcast. Real EMS conversations, zero corporate polish, and education that actually applies at 3 a.m. You can find CMEs, merch, and everything else we're building over at medic-materials.com. Until next time, stay safe, eat a donut, and please, for the love of God, answer your QA flags.